Okay. If a joint. Did you leave a feedback on mfmleague.com?
I did.
Okay, good.
I didn't see it.
I got it. All right. If it's a joint is causing the primary pain, then it's best to do movement that balances the joint optimally with minimal movement within that joint. Got it? So somebody give me an example. So if somebody has, let's say, meniscal, right? That's joint, yeah? Meniscal pain in the right knee. What do? How do you apply this principle? I want you to do, now, I know what we used to do, right? What would we do with meniscal pain? Come on. I'm not saying you do it, I'm just saying tell me what we used to do. Straight leg raises, okay, no, I gotcha. Huh? Who? Someone said ball squats? You did? You just don't go too deep? Okay. Okay, what else? For menisco. Huh? What else would you do for meniscus pain in the knee, right knee meniscus?
Sitting position, you raise the knee.
Okay, so you're working the hip flexors, psoas a little bit. So do some open chain, quads. Okay. Anything else? What else would you do for meniscus?
My PT used to
Put you on the bike? Yeah, you know, they would do that kind of stuff. Horrible, stupid, but I used to do that too. I used to put meniscus patients on the bike. I'm just saying we just kind of like forget that, you know what, there's a best movements, and then there's just fluffy shit, and then there's stuff that is just totally, it's like, what were you thinking, right? Because if we don't master our craft, we're not going to impact lives. So, but when there's a meniscus problem, where do most knee issues originate? Core. Where do most hip problems originate? Right? So what I'm saying is, you guys, right, kinematic chain, we know that, but why do we not follow it? So, just like Sarah was saying, let's get the hip. Let's get the hip going, because if you're sitting there doing like patellofemoral, I don't know how long I should fucking do quad sets, and I would even put electro. You know, like I would like have it on one of those beep 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 beep, right? What are those called? Biofeedback? And right on that VMO, like somehow, like the results were just so slow. I'm not saying we didn't get results, but it was just so slow. Now, once you start to understand the lateral subsystem, which is made up of which musculature? Adductors.
And contralateral QL.
Adductors.
And that's huge.
I'm going to tell you right now, rehab, they don't even know what adductors are. The only thing that in rehab adductors is this. This is adductors in rehab. That's it. Okay, and that's horrible, because if you don't engage the adductors, this is engaging the adductors right here. You know how important the adductors are? Anyways, very important. This is adductors right here. This is getting the adductors working on both sides. This one's stabilizing. This one is starting to get reciprocal inhibition, because most of us, adductors are so weak that they're so fucking tight that we need reciprocal inhibition to start opening that up. Do you understand what I'm saying? And then now, once we start doing axe kicks, working the adductors and the gluteus medius, external rotators, stabilizing on this side, but then we're actively working it on this side.
So what is the stage one? So for example, you have somebody with meniscal pain and the person is not able to stand on one leg. I usually start them with those like supine exercises, bridging and hip abduction.
Yes, that's where you should usually start. But I want you to progress them. But start there. Let's do a bridge. Let's make sure they don't. Pardon?
To get them to stabilize stance. It's okay. Sounds like.
What's your question?
So first three, 4 sessions. It takes like 3, 4 sessions to get them in standing. Does that sound like reasonable time
To get them standing?
to get them to kick?
Oh, no, you're going to see, like, let's say, are we talking patellofemoral or meniscus? Because I kind of brought up both conditions.
Both, yeah.
No, pick one.
Okay, let's say meniscus.
All right, so if they have a meniscal problem, let's say it's right. I always reference to right, just to be consistent. So let's say they have right knee meniscus pain. Okay, and let's say, I always look at, I break down patients into 3 categories: 55 and over, 55 to 30, and 30 and lower. All right, so, because I approach those differently. And this is a really generalization, right, you guys? All right, there's exceptions. There's some 55-year-olds that look 30, right? So, but anyways, so let's say this is probably the greatest population, which is from 30 to 55. Right knee meniscus problem. You're going to see, if you're going to see the right knee meniscus diagnosis as a patient, they're going to be, most of them are going to be between age of 30 and 55, right? So let's say they have the right. We want to work the hip, the psoas, right? How do we do that? But here's the thing. If their acute pain is higher, irritable, do you want them to be doing this? Why not? What's wrong with this? This is going to increase meniscal pain?
Yeah.
This is going to increase meniscal pain. How does this increase meniscal pain? This, if I was doing this, would this increase meniscal pain potentially? Yes. Condyles are right on the meniscus when it's bent at 90. Like that. But here it's opened up. This is actually a closed chain on the knee with the knee at 90. So now you've got the femoral condyles right on the meniscus. This doesn't. Patellofemoral, you don't want to do this, right? But for meniscus, you can do this position. So you can start getting the psoas on this side. Start getting them doing positioning movements with this. Everyone get off your seats for a sec. So imagine all right, so have your right knee down. We're in, what position are we in? All right, lift the knee, and then I want you to reach for that other heel. Reach and exhale and reach hard. What do you feel? What do you feel? Where do you feel the most tension? On the right quad, yeah? But you're actually also feeling it where? Psoas. Now you don't obviously so deep, you don't always recognize the feel of it. Do it again. Lift that knee up, and then turn back and try to touch that. Exhale and even go farther. Really? Anyone can anyone touch that heel? Probably the only person is Liz Wally. I think she's the only person in this. Huh? All right. So now, if this was 30 to 55-year-old, they're not going to be able to touch the heel. But have them working out. So they're literally for 10, 15 minutes, this is all they're doing. This is all they're doing. And so if this is like an acute situation where their pain is a little high, you can have them. Now, If they can't tolerate this for whatever reason, then what do? Let's say you have them do this. Let's say you have them do this and get into this, and then you say, okay, any pain with this? And they say, yeah, this is not good.
Downgrade it.
How do you downgrade it from there? All right, you guys. Okay, so now we get into quadruped. What do we do from here? How do we work the psoas, the hips from here? You guys just lift your knees. Let's just lift the knees. Now, what do we do from here? Do we externally rotate as we lift up? Do we, as we extend the hip to get the psoas, what are we trying to do? We're trying to get the psoas, right? Do we externally rotate the hip?
Yes.
Everyone say yes. Yes. Do 10 of those right now. Squeeze your buttock. Squeeze that buttock. Okay, now what else can you do? What else can you do as you're externally rotating and hyperextending the hip? Now what else can you do? Reach. Touch that heel. Opposite arm, opposite arm. Opposite arm. There you go, Sam. There you go. Can you reach? You guys, this is a 30 to 55. Don't treat them like they're fucking elderly. It's insulting. Challenge them. Challenge them. You guys, I'm 64 years old. You better challenge me. Treat the 30 to 55-year-olds like they are still in their youth. They will love you. They will love you. Everyone do 10 of those. Now switch to the other side and do 10. Tell me which side's stronger on you. Do the other side. 10 of them. You guys hyperextend that hip. If you don't, you're not going to impact the psoas as much. Hyperextend that hip. Really squeeze that glute. Get that heel closer to your head. Get that heel closer to your head. So it's easier to touch the... This is a meniscus patient. Do you get the glutes when you externally rotate and hyperextend? Do you get the posterior oblique system? You get the lats? You get the hamstrings? You get the psoas?
Everything.
You guys, you get it all. Have them do this for 10, 15 minutes. The next day, they'll be sore. But you know what? They'll feel younger. They feel younger. Because you got all the cells opening up. You got the whole myofascial system network. Pliable. They're lubricated. You guys, people feel young. They're like, I love you guys. Don't be sitting there with a biofeedback unit doing a quad set. Do you understand what I'm saying? Don't be sitting there doing leg extensions, knee extensions. The problem's not in the fucking knee. The problem's in the fucking hip, in the psoas, in the core. Get the fucking core. Everyone say, get the fucking core. All right, take a break. Bathroom break. Come right back.